welcome on behalf of the Americas section of the International Society of Respiratory Protection. I'd like to welcome you to today's seminar on respiratory protection for the public and workers without respiratory protection program. I'm honored to introduce Dr. Aurora Lay. She is currently an associate professor in the Department of Health Behavior at Texas A&M University School of Public Health. Her research interests center around occupational health with specific focus on occupational health disparities, occupational justice, psychosocial factors of work and workplace behaviors. Dr. Lay's practice-based work includes worker training and education, adult curriculum development, infectious disease mitigation, and management from an industrial hygiene perspective. In the past decade, she has trained over 3,000 workers nationwide through various National Institute of Environmental Health Science worker training programs on various biohazard and PPE topics. With that, welcome Dr. Lay. I would encourage the participants to use the chat or the Q&A feature, and we'll try to address questions as the seminar goes along. Thank you.
Wonderful. Thank you so much for the introduction, John, and thank you everybody for joining today. I don't think I'll take the full hour, but as I mentioned, I welcome questions that I'll be taking at the end to put in the Q&A function or the chat. So let me just get started here. So part of it is that I am part of the National Institute of Environmental Health Sciences Worker Training Program, and specifically I'm part of the Prevention, Preparedness, and Response Consortium. So my time in front of you today is being brought to you by them. And just to provide a little bit more of context on why I'm specifically presenting this to you today, not just a random person they plucked out of obscurity. So I have been part of the worker training program since 2015. I'm also currently a faculty director for the Texas A&M University Center for Worker Health. In 2015 to 2016, I was a research assistant for the Nebraska Biocontainment Unit prior to the CDC designating Ebola treatment centers in the United States. So the Nebraska Biocontainment Unit was only one of 3 facilities that were high-level isolation units at that time in the United States that were actively treating Ebola patients that were repatriated here into the United States. And so through that, I had the opportunity to get involved into the world of highly infectious disease containment. From 2016 to 2020, I was the program coordinator of the Biosafety and Infectious Disease Training Initiative, which was an NIHS-funded worker training program. And then for 2 years, I contracted with the University of Nebraska Medical Center, Center for Global Security, and ASPR and the National Disaster Medical System to develop training curriculum for their personnel. So that's what that picture is their 2018 NDMS Training Summit. If you can spot me, we were tasked to provide them beforehand the summit training on level C donning and doffing, actually go through the exercise with them there. And then in subsequent years, I helped develop some of their training and education on highly infectious decedent management, packaging, testing, transportation, and so on. And then between 2021 and 2023, I was an IPA for NIOSH, specifically for COVID-19 for the construction sector. And so my colleague and I, Dr. Sean Gibbs, who is one of the industrial hygienists who focuses on highly infectious disease disruption, we gave this presentation at the American Industrial Hygiene Association conference back in May, and through that connected with NIOSH and PPTL and John, and that's why I'm being asked to deliver this presentation to you today. So in response to the COVID-19 pandemic, the National Academies of Sciences, Engineering, and Medicine tried to quickly put together this task force to essentially publish a very lengthy book, a lengthy publication on respiratory protection, which all 500 plus pages are available online for free. The DOI for that publication is there on the PowerPoint slide. But specifically for Chapter 4, Chapter 4 focuses on protecting workers and the public from inhalation hazards. So this encompasses workers who do not have mandatory respiratory protection programs, but we saw a huge volume of folks using personal protective equipment, respiratory protection, makeshift respiratory protection for the first time. And so this whole chapter, which you again can download for free off of their website as a PDF, it's about 60 pages, was to try to discuss some of the challenges faced because there is currently still no single coordinated body or singular evidence-based consensus on what we should do for respiratory protection outside of the workplace. So again, just wanted to thank the Committee for Respiratory Protection for the Public and Workers Without RPPs in the Workplace and the NASEM study staff. But in particular, when we're looking at the core functions of the committee's framework for oversight and guidance in regards to respiratory protection, what they're trying to achieve is essentially a life cycle of learning and continuous improvement for respiratory protection. So not only does that include determining necessary respiratory protection devices, but we're also looking at the availability and access to pathways for respiratory protection devices. So that does include supply chain issues as well, engaging, informing, and ensuring targeted communities have access. I'll get to all of these points in detail in a little bit. Developing and approving respiratory protection devices, assessing hazards, and so on. And with all of that, the most important part of this all is coordination, which coordination is something that we continue to see was a struggle during the COVID-19 pandemic and continues to be a struggle to this day in regard to the general public and workers that aren't part of an RPP. So essentially the objectives of this study and this chapter that they put out for the general public and workers without an RPP were to essentially identify scenarios where the public was not part of a respiratory protection program, but may benefit from wearing respiratory protection. So obviously this is more than just biohazards, but during the COVID-19 pandemic, we saw all kinds of wild things in terms of what folks were wearing for respiratory protection. It seems like so long ago, 4 years ago, but just to refresh you, some folks we saw on social media even were using like 5-gallon water containers and cutting out holes to put over their head. Some people were wearing actual like adult diapers as forms of respiratory protection. I remember very early on, probably late February, early March, when there started to be supply chain issues, trying to make my own cloth mask covering out of several pillowcases, and I didn't have a sewing machine myself, so I was trying to hand stitch it, and I was using old elastic from pant waistbands that I didn't need anymore that I was cutting out, and then just an absolute chaos of a mess. And then we started to see a lot of different surgical masks enter essentially the public space in terms of being available to purchase on Amazon. There was a shortage of N95s, so we started to see KN95s enter that were being manufactured from abroad. More limited use of elastomerics in public, but just a slew of different types of surgical masks being circulated in the public, widely available in many places, including physicians' offices, but seeing people use it to varying degrees of proficiency. Some putting it on their head when they're not wearing it, slipping it down under their chin, wearing it but not fully covering their nose, people wearing their surgical masks or N95s, and then when they're not wearing it, folding it in half and placing it in their pocket and then reusing it over the course of many days or many weeks. Folks keeping it in the dangling it from the windshield, the rear mirror of their car. So whatever confirmation of use and non-use and and care and not care, we definitely saw it all. But in addition, now we are having to consider use of respiratory protection for things beyond biohazards, like environmental contaminants. And especially with the rate at which the climate is changing, we are experiencing a more frequent cadence of severity of climate related events. And that includes things like wildfires, for example, or even man-made fires that then propagate into large multi-acre, 1,000-acre fires. And so this picture here was just from last year in Lahaina, in Hawaii, as you saw with the wildfires. My mom lives in Northern California in the Sacramento Valley. And so during the COVID-19 pandemic, there were also wildfires going on in Napa, California, and Northern California. So folks were wearing respiratory protection, not only for COVID, but the skies for 2, 3 weeks on end were just a hue of yellow because of all of the dust, visible windshield on the dust, visible windshield because of the particulate matter. So environmental contaminants are now becoming a larger issue as well. So with this NASEM chapter, they're also trying to describe the challenges and limitations with the public's use of respiratory devices. And with me, what I'll discuss a little bit more in detail, because my doctorate is in health behavior, discussing the behavioral and educational considerations needed for effectively ensuring that the public and workers without RPPs are using that equipment correctly. And so this is in the NASEM report where they do provide, I'm going to show you a couple of call out boxes from the report. Again, you can read this afterwards in greater detail, but there's a couple of diverse circumstances in which the public might require respiratory protection. So for example, right now we have the 3 scenarios. First is an individual in March of 2020 in Scranton, Pennsylvania, who wakes up and learns about the COVID-19 pandemic. I'm not going to harp on this any further, but as of today, we are seeing another wave of COVID again. As somebody who teaches at the university setting, last week was the first week of class, and I've already had 3 students who missed the entire first week of class because they said they tested positive for COVID. So I know as of this week, I believe Walgreens and CVS is rolling out another COVID booster, as well as making the Mpox vaccine more readily available to the general public. So a second scenario that they just discussed that I talked about briefly is in 2020 in Monterey, California, high levels of smoke creating great particulate matter in Salinas, about 20 miles from the fires and where it's actually occurring. And then the third scenario, which is an individual returning home after a major flooding event, finds significant mold growth requiring remediation. And now that I live in Texas, we just had the hurricane come through here not too long ago. I think it was June. What is time? Time is a construct. But my colleague who lives in the heart of Houston did not have power in her home for over a week. That was due to various infrastructure issues. But Houston, and in particular Galveston and the Gulf of Mexico, there is a known hurricane zone. And so you have folks living in parts of Texas, Louisiana, and so on, who are always going to be Florida, constantly affected by flooding events. And a lot of folks in the general public don't realize that most mold remediation requires complete removal of the materials that have mold. Things like bleach solutions often don't work because if you're not 100% getting rid of the source, if there continues to be moisture in a food source, it will continue to grow, right? But we see people also sometimes wearing respiratory protection during their personal home mold remediation and sometimes not. So another call out that we wanted to discuss are questions. These are specific questions that the general public may have about respiratory protection devices. And with this, I'm specifically talking about FFRs like N95. So where should I look for for information on the need for respiratory protection? Most folks don't even know what NIOSH is, I'll be honest with you. And during the COVID-19 pandemic, the CDC lost a lot of credibility with the general public and even amongst the public health community. So nowadays, obviously more folks, they're not going to be prone to going to government affiliated websites, even the NIH, just because of the distrust that was sown during the COVID-19 pandemic. I would say as a public health practitioner, the amount of damage that was done during the COVID-19 pandemic, just because of not great communication from the CDC and various administrations, and a lot of increasing sentiments about vaccine hesitancy. I feel like talking to my colleagues, we probably set public health efforts back by a good century. So it does keep us busy, but it's grim times. So most people honestly are looking for their information on respiratory protection from their employer directly, from the professional organizations, from the local news, and from social media. And social media has a lot of misinformation out there. There's also some good information out there, right? Um, Folks don't also understand the circumstances in which they need to use a respiratory protection device. So for example, I will tell you, the other day, I was watching this Netflix show called Resurrected Rides. It's by the same people who used to make Pimp My Ride, if you remember that MTV show from back in the day. But there was an individual who was doing uh, some resin mixtures and some chemical mixtures, and all he was wearing was an FFR, which anybody on this call knows that that doesn't protect against any volatile organic compounds or chemical hazards in the sense. Folks don't also understand, the general public, on how to get information about use of the device in terms of manufacturers' recommendations on maximum use concentration. They don't know what an MUC is. They don't know where to get that information. Donning and doffing is a huge issue among the general public. When should they use it, indoor and outdoors? How do they know that they're being protected from the hazards? How do they know that the actual device is protecting them? When should it be discarded? How safe is it for them to use? We saw this a lot during the COVID-19 pandemic, where there were a lot of conversations about folks not wanting to wear respiratory protection because they believed it would build up the carbon dioxide within their mask, creating further health conditions, right? Folks don't understand about different fabrics, filters, closures, and finishings, what will cause them harm. A lot of FFRs that did have the exhalation valve on them have now since been taken off of the market for the general public. A lot of people have questions about health challenges, especially if they have pre-existing conditions with lung or cardiovascular issues, right? But people are also very skeptical about whether or not these devices can actually reduce their risk of getting the exposure or the disease. And so I think one of the major challenges, especially for when we're talking about using respiratory protection within the realm of biological hazards or environmental exposures, is that the answer to them is a lot of times, for everybody's unique circumstance, it depends, which is really unsatisfying for somebody who's in the general public, or for a worker that doesn't use respiratory protection as part of a mandatory program, because it depends is so nebulous. That's why a lot of folks just err and end up thinking, okay, well, if you don't have a direct answer for me, or if you can't quantify this for me in a satisfying manner, like what is the point of me wearing it in the first place? And they will forgo it. And I find that, and we were talking about this a little bit at the American Industrial Hygiene Association conference, the major issue is that throughout the United States, among the general public, there is a lack of understanding of general scientific principles and health principles that are core and foundational to understanding what respiratory protection does for you and why it does actually matter in the right circumstances. But because folks don't understand basic things about even how humidity and temperatures can affect aerosol dynamics, for example, or things like electrostatic uh, attraction. Um, all of that is very complex when we're talking to the general public, and because they don't have those foundational principles of some very basic scientific knowledge, I'm not asking them to be experts on particle dynamics or even public health or virology, for example, but just very basic scientific knowledge is completely lacking in a good chunk of the population. And so for these questions about that the general public will have about respiratory protection devices, we as professionals need to remind ourselves that and scale it way back to the very beginning. And I even put a little asterisk down there about putting further training for healthcare workers in the United States on personal protective equipment. A medical student or a nursing student who has 4 years of curriculum, they have so much to cover during that time. And I've asked my colleagues who have gone through medical school, aside from, knowing that you have to scrub in and out of procedures and wear certain types of PPE when you're doing things, how much time in your 4 years did you actually spend learning about PPE? And they said maybe 1 to 2 hours maximum. And these are people in the healthcare setting who are using it on a daily basis, who are probably part of a RPP, and they themselves don't even understand what the principles of selection, use, maintenance is for respiratory protection devices. Back, for example, during the Ebola outbreak in 2014, when we were working with some of the medical staff that were rotating through the biocontainment unit, we had a volunteers only model of staffing because we didn't want to force anybody to do anything they didn't want to do. And we had one physician who was wearing an FFR tell us, hey, I feel like my device, it was an N95, I feel like my device is working, it must be working really well because as the day goes on, it's getting harder for me to breathe in it. And to those of us who are industrial hygienists and work in occupational health, we know that is not a good indicator because that point, the filter is probably saturated with saliva and a bunch of different contaminants from the interior and exterior, definitely. So at that point, that MD definitely needed to change their FFR. But because that is not a fundamental part of their training, and they did not understand that with them not being able to breathe well in the FFR indicates that we're actually probably needing to change it out because it's no longer effective. Those things are still very persistent to this day in terms of understanding the principles and answering questions about what folks might have for respiratory protection devices. Now, for what's available to the public, we again have our elastomerics, our FFRs, PAPRs, I would say is less common among the general public just because of how expensive they are. But we do see a lot of medical masks, barrier face coverings, and then cloth face coverings in particular. I will say with the general public, I have mostly seen the bottom row, right? Because when we think about user needs, what folks care about most is it a comfortable? Is it aesthetically pleasing? Does it impair your vision or communication? Are there clear instructions for use, or is it pretty easy to use? And is it reusable, stable, and durable? A lot of places already provide medical masks free of charge. Many local county health departments were handing this out for free. For folks, this is more intuitive to use, just because at the top there is a visible part where there is a small metal band that goes on your nose, and then you can, conform it to your facial features, accordingly. Obviously, the seal is not going to be nearly as tight as an FFR, but for folks, the aesthetics and the comfortability, it doesn't feel as quote unquote claustrophobic as an FFR, for example. I'm sure you have seen, and a lot of folks have seen throughout the last 4 years as well, gentlemen with just full, very full lumberjack beards, wearing a tiny little surgical or procedure mask over it. And while I commend them for wearing a mask, because a lot of people would not make the choice of wearing it if they had to, right? Also, the general public does not understand how things like facial hair, extensive sideburns or mutton chops, for example, or even orthodontic devices or facial scarring can affect the seal of their mask. For folks like myself who wear glasses, understanding that if there's not a proper seal, there's a lot of fogging of the glasses. So I know many folks that I've talked to who wear glasses opted out of wearing a mask if they didn't have to, just because it was impairing their vision as well. Um, and now we also have the issue, as an aside, because there's so many of these devices readily available to the public, the how do I say, laxness? I don't actually know if that's a word. People are getting very lax about how they use them and care for them. Again, so we see people constantly like folding it up, wadding it up, putting it in their pocket between uses, and now contaminating the inside as well, uh, storing it in odd places. And there's also the environmental sustainability issues that we haven't discussed at length in many venues as well. And now in a lot of waterways and various bodies of water and a lot of landfills, and a lot of developing countries where our trash ends up in the United States, we're seeing a plethora of used masks, just because obviously the materials that these are made with do not break down easily in the environment. So now that's another contaminant to consider. So, um, again, there are many challenges and limitations to the public's use of personal protective equipment. So, here, if we look at OSHA's requirements in terms of voluntary use of respirators, they have this flow chart here. Is it necessary or is it required by the employer? Yes or no. If it is, they must establish a formal RPP. And then if not, does the employer permit voluntary use of respirators? Yes or no. If yes, does it only include FFR? Yes or no. And then from that, the employer follows the according tasks. But again, like we've discussed before, there is uncertainty about the effectiveness of current devices against varied inhalation hazards. Because things with biological hazards, we don't have any direct rating devices to immediately quantify the pathogens in the environment, for example. We do have some reading devices that can look at particulate matter, but taking that into consideration with different environmental contaminants, and what folks' pre-existing conditions might be, that requires more extensive risk assessment modeling that can't be done instantaneously, right? And then we also have such a heterogeneity with the population as well. Respiratory protection devices are largely used in workplaces, and workplaces consist of adults, largely. Although child labor is on the rise here in the United States again, but that's a topic of a whole other conversation. But one issue that came up in particular is during the COVID-19 pandemic is, okay, what about respiratory protection for infants and children? Again, most PPE manufacturers, most respiratory protection device manufacturers do not initially have infants and children in mind because they are not captured in the workforce. So I know that is a particular interest to the International Society for Respiratory Protection, so I won't harp on that too long. But currently, there are some makes and models of devices being tested with infants and children, but to the best of my knowledge, nothing that is widely approved or distributed. The elderly in particular also find challenges with proper fits for respiratory protection devices, just because the bulk of respiratory protection is developed again for a young or middle-aged workforce. As you get older, obviously you lose some muscle mass and tissue densities, particularly in the face, that can make a proper seal more challenging. Then you have folks with chronic health conditions to consider of various respiratory nature or even cardiac nature that can make considering wearing respiratory devices a more extensive conversation with their healthcare provider, who again, as I previously mentioned, probably does not have that much training anyway on PPE in the first place. And then you have folks with physical or mental disabilities who may also encounter various challenges when trying to select or wear respiratory protection for an extended period of time. Furthermore, there is a general absence of fit testing for the general public. As mentioned in the introduction, I've done many worker trainings over the last decade. And with that, I mostly focus on non-healthcare workers. So that means going around to emergency medical service personnel. I've trained a lot of public works and utilities workers. And one of the things that I always have to retrain folks on is doing a seal check, and then discussing with them the difference between positive and negative pressure. And a lot of folks still, if they're not using personal protective equipment or respiratory protection on a regular basis, fit testing honestly falls by the wayside. So it is, again, like any habit, something that has to be drilled into them and practiced regularly, or else they're not going to do fit testing. And when they purchase an N95 on Amazon, and they get the cup fit instead of the trifold, they're going to feel like it's super tight on their face because they might be getting the 1860S, not realizing that it's generally only recommended for people below a certain size. Or for folks wearing the FFR that is a trifold, like the 9210, for example, not realizing that it folds out into 3 parts, essentially. So I've seen folks wearing those just with the single part across their face unfolded. There's also, again, we talked about that, health risks. I'll skip over that because I feel like I've talked about that already, but also devices and medical clearance for the public. There's, again, no singular body that is responsible for doing this. So with this, now I want to move on to discussing some behavioral and educational considerations. First, I want to put out this is another pop out from the study, which I'll discuss in a minute. But with this in particular, the crux of making anybody do anything is knowledge, skills, attitudes, and beliefs. And as somebody who does interventions in public health, the only way you can make anybody change their health behavior in anything is 2 questions. Is it fun? And is it easy for me to do? And a lot of times the question is no. And so that's why many health behavior interventions fail, right? You honestly can't tell anybody to do anything, even if you give them all of the knowledge. People know that smoking is not good for them. They still are smoking anyway, right? Because there is that addiction component. They might have different attitudes or beliefs towards it. So all the knowledge in the world is not going to change that. So when we're thinking about behavioral change considerations, you need that confluence of not only knowledge, but also skills, attitudes, and beliefs. So when we're thinking about respiratory protection in particular, I think we all saw this during the COVID-19 pandemic. It became particularly underscored to us what an individualistic society America is. Because in cultures across of the world that are more community oriented or community focused, we saw higher rates of mask usage. So, for example, in Eastern Asian countries like Japan or Taiwan, even prior to the COVID-19 pandemic, because the general public there has that basic understanding about respiratory particles and how you arrest respiratory particles coming from your own mouth, you would see folks in China, Japan, other parts of Eastern Asia wearing a mask in the public when they had a cold because it was out of consideration for your fellow person. Even here, working in university settings, when we have international students from Eastern Asian countries, you see them even prior to the COVID-19 pandemic voluntarily wearing a mask when they're not feeling well because they don't want their droplets spreading everywhere. Um, so that is, again, the difference in terms of like beliefs, but also cultural beliefs as well that factor into that. During the COVID-19 pandemic, an extremely low, what we would call a lower resource country like Vietnam, for example, had extremely low rates of COVID-19 pandemic fatalities, just because folks there, for different reasons, I myself am Vietnamese, people there really listen to their government, but also, again, that consideration about doing what's best for the general community. They understand that respiratory protection was a huge component of that. Um, Here in the United States, we saw some interesting things happening as well in terms of attitudes and beliefs and looking at group norms in terms of who's wearing respiratory protection and who is not. People often follow their peer norms and what is expected from that in their community, whether or not that is aligned with their political affiliation and beliefs, or whether or not they are rural versus urban. And we even saw a lot of racial and ethnic differences in terms of mask usage, as well as gender differences in in mask usage as well. So a couple of studies actually focused on mask usage differences between people who identified as women and people who identified as men. And men actually wore masks uh, less frequently than women, just because, again, of attitudes towards mask wearing, norms, and interestingly, toxic masculinity factoring into this perception that wearing respiratory protection, even during the COVID-19 pandemic, made them appear weaker. And so, because they did not want to appear weak, to their amongst their peers or amongst their community, they decided not to wear a mask. So again, understanding whether the kind of communities that you're working in, where you're trying to be an advocate for respiratory protection, doing, I know maybe it's beyond the scope of what you traditionally do, but doing an assessment of knowledge, attitudes, skills, and beliefs towards respiratory protection can make all the difference because you can put out all the policies or guidelines or do all the trainings that you want about respiratory protection. But if you don't have an underlying understanding of why folks are not complying or utilizing it in the first place, anything you do after that is honestly not going to be successful. So keeping that in mind. Additionally, there are very few evaluations of interventions regarding respiratory protection among the general public. Lots of studies on this in the workplace, but in the general public, there is not. So you can see in this call out box here, this was provided to you in the NASEM chapter. They actually did a study to look at a distribution program of respiratory protection in Israel. This was quite some time ago. Okay, so this is not recent, but essentially they looked at the military there worked with the education ministry to essentially establish emergency drills in schools to teach them how to measure respiratory protection devices, don and doff them properly. Very much like here in the United States, how you would drill kids, with me growing up, earthquakes, with kids now, mass shootings. But there in Israel, they did that for respiratory protection devices. And so they were able to do, um, essentially a public school intervention with that. But here in the United States, we have very few interventions actually with the general public on how to measure the effectiveness of any kind of uh, knowledge or training that we impart upon them. Um, Also improving effective use. Still, again, we don't know that unless we know what the barriers are. So once we find out what the barriers are, whether those are attitudinal barriers, skill barriers, knowledge barriers, a lot of times they're economical barriers as well. Um, so folks who are considered low socioeconomic status, low income, may not have access to personal protective equipment that they desire to use. So as we saw during the COVID-19 pandemic, once the supply chain wasn't as locked up, we saw a lot of local county health departments using points of distribution like Walmart, for example, churches, community centers, to get folks masks, surgical masks, if they needed them. I was living in the Detroit area during the COVID-19 pandemic, and there were multiple opportunities for me to go if I needed to, but I didn't need to because I was fortunate to have access points for respiratory protection, um, to access it if needed. And then with subpopulations and communities, when we're thinking about educational considerations, one of the important things that we have to keep reminding ourselves, especially if we don't regularly interface with the general public, is only about 50% of the United States has a reading proficiency beyond the 8th grade. And those are for people who are fluent in English. Okay. So when we're putting out educational materials or media information, infographics, thinking about the literacy rates in which the general population reads it. Um, Oftentimes, if literature is too scientific or complex, that's really off-putting and people just mentally shut down. Or depending on the population that you're trying to reach, using lingo that is too um, scientific or niche in particular can be seen as elitist. And therefore, before you even have the chance to convey the message that you're wanting to convey, their mind is already shut off to the opportunity for receiving that information. Again, because going back to whatever attitudes, beliefs, group norms they might have. In addition to this, we have tons of people here in the United States who speak a second language, a third language. English is not their first language. With the wildfires that we saw, particularly in parts of California occurring in the valley, those valleys historically are where our centers of agriculture are. And so there were some really prolific news articles that you see where you have migrant farm workers who are wearing bandanas around their face because they don't have access to FFRs, uh, picking produce while the sky behind them is pitch black and the sun looks red because of all the particulate matter. And those folks who exclusively speak Spanish or they only speak one of the Hmong dialects, for example, are going to need this respiratory protection conveyed to them in a sense that is not only linguistically appropriate to them, but also culturally appropriate. I'll give you an example that's kind of tangential to this, but to display to you the importance of linguistic appropriateness. Back when I was doing my master's degree, I was looking at psychosomatic issues amongst Bhutanese refugees. So these refugees from Bhutan were in their 20s and 30s, perfectly healthy, complaining about chronic pain. The physicians had done all the scans, CTs on them. Their body is fine. It was all psychosomatic pain. So when I wanted to talk to these Bhutanese refugees about mental health, uh, because of their language, is no actual word that provides the nuance in their language for differences between like despair, depression, grieving, trauma. They only had one word for sadness in their language, and that sadness directly translated to the sadness you feel when someone passes away. And so I would actually highly recommend y'all, if you are trying to create multilingual educational materials or training materials, to not use artificial intelligence, because it's not the best. So even with materials that I have translated to Vietnamese for nail salon workers that I work with, we have to forward translate it English to Vietnamese, back translate it Vietnamese back to English to double check that it's correct. Just because even there's with the different dialects between northern and southern Vietnam and central Vietnam, people have differences in the ways that words are used, the vocabulary that's used, more like colloquial sayings that folks use. When we used AI for one of our training modules, we translated it from, we wanted to describe someone as a hypochondriac. I kid you not, the AI translated that to Vietnamese, hypochondriac to erectile dysfunction. And so you never know what you're going to get in terms of multilingual translation. So I highly recommend you to actually use native speakers when you're developing these materials, to not only make sure that it's linguistically appropriate, but the translation is not so formal. It has to be able to reach folks in that language at about a 4th or 5th grade level. Okay. So what you can do, I see some, let me look in the chat really fast to see what's happening. There's questions. Okay, I will get to that at the end. What you can do, part of it is your expertise in creating, again, understanding and conveying information on the physical and psychological descriptors of who your population is that you're trying to reach, that wears this respiratory protection, understanding what exposures they're trying to reduce, and then creating materials or education on the selection of devices. Most importantly, I feel the general public is missing information about limitations of the device. What does it do and what does it do? Not do. Putting on a mask does not make somebody infallible. And oftentimes, again, we find people using now FFRs for chemical exposures as well, where that's not appropriate. And lastly, again, conveying very basic information on device use, maintenance, replacement, and etc. I had the opportunity in 2022 to write this NIOSH science blog specifically for construction workers on respiratory protection. So in the construction industry in particular, we already have some workers that are covered by respiratory protection programs because they're already working with things like silica or wood dust. But the question came up, what about the workers who are on the work site who want to use it voluntarily, like an FFR, because there might be a COVID outbreak, for example, or in the future, for sure, we're going to have another respiratory pandemic or outbreak of some sort. I can guarantee you that, probably in the next 5 years. So what are we going to do with those folks? The employers who have workers under the voluntary program are not obligated to provide them that respiratory protection free of cost like they would the workers who are under the RPP. But the employers must be aware of it and at least provide some training on the principles of respiratory protection. And in this NIOSH science blog, I get into a little bit more what the employer obligations are, if at all. But if you're encountering a workplace or a workforce where you already have workers who have some understanding, some use, some principles of respiratory protection for different circumstances, definitely capitalize on that to start discussing voluntary use and then use as a general citizen. So, okay, I said I wouldn't take the whole hour, but here I go. you don't get a PhD without liking to hear your voice all the time. So at this time, I'm gonna look at the Q&A box, but it would be very helpful for me if you could fill out a short evaluation of how I did. You can either use the QR code to scan, or there's a short URL there. So I'm gonna look now in the Q&A box. I see Simon said, "Hi, I'm assisting with the IRSP contribution to the FACEP program. A couple of questions. Number one, is there a benefit in creating a worldwide standard for respirators or face coverings for children? And then number two, oh, sorry, or is it better to cover regionally due to different potential needs? And then two, can you advise on sources on data for facial dimensions of children in various regions geographically to assist in developing standard requirements?" I'll start with the first question. Is there a benefit of creating a worldwide standard for respirators or face coverings in children, or is it better to cover regionally due to different potential needs? I will be very candid with you that children are not my bag. Generally, I don't interact with many children. And specifically, respiratory protection in children is not something that I have explored extensively, aside from, like my friends or colleagues who have children asking me during the COVID pandemic what my thoughts are in terms of what devices they can use. I would err on the side, just from what I know from my health behavior background, is that there is no such thing as a general intervention or a blanket intervention that's going to work for everyone. So I would say that I would say that it would be more appropriate for me to think about regional differences in terms of covering potential needs for respiratory protection, because again, you're going to have those gender norm differences. You're going to have those racial and ethnic differences as well. During the COVID-19 pandemic, I've read a couple studies where people who are non-Hispanic whites were less likely to wear respiratory protection than people of color, Black, Indigenous, Asian American. And that, again, it comes from different beliefs and norms, but also you have to think about the social determinants of health in regards to people's access for healthcare, whether or not they can afford to get sick or not, whether they not can afford medication or an emergency visit. So depending on the situation folks are in, some might be more convinced to use a form of primary prevention or primary protection because of their circumstances. So I would definitely opt for regional differences in children as well, just because of those different norms. And then also things in terms of like hairstyles, or if you're dealing with a population, for example, worldwide, where abroad, in a lot of Middle Eastern countries, for individuals who practice Islam, where women are already covering up to a large extent anyway, how can we integrate potentially respiratory protection for those children into their ensembles? So that would be my initial thought. I don't particularly know off of the top of my head any data sources for facial dimensions on children in various geographic regions. Uh, Other than the fact that if you look at like genetics, for example, there may be information on how facial conformations from people from Eastern Asia different from Southeastern Asia, differ from indigenous people who live in Alaska. And from that, using at least the adult genetic information and what we know about the proportional ratios to children's faces, to do some back calculations from there. But unfortunately, to the best of my knowledge, I don't know of any existing repositories that have information for children on that. So I'm sorry that's not a more satisfying answer, but it sounds like a cool grant question that you could potentially propose as an NIH proposal, and get a bunch of research money for that. So yes. Um, okay. I don't, oh, let me see. Okay, all right. I don't see any other questions from the audience. I know I talked so much. I'm really tired. But again, if okay, someone else has a question. Even though all the issues you brought up were addressed, I think human error on donning face piece might have a significant effect on protection. Did you have a chance to look on this aspect? Yes, there are a lot of studies on donning and doffing efficacy in terms of human error and human behavior. And I have a colleague at University of Nebraska Medical Center, Beth Beam. She's excellent. And if you look at their website, UNMC Heroes, Heroes plural, they have a large educational repository of YouTube videos, including one that I helped her develop for the general public on donning and doffing FFRs. We find the issue with donning in terms of, especially with FFRs, people not understanding where they need to place the straps on their head. We see a lot of folks doing crisscrossing. We see a lot of folks not doing seal checks. We see a lot of folks not using the metal band in the nose piece to conform it to their nose for a proper fit. But I would say the larger issue about donning incorrectly, the largest issue is the doffing incorrectly, because that's where most of the cross contamination can happen. And that's what we saw with the two nurses who were treating the Ebola patient at Texas Presbyterian here in Dallas back in 2014, going back through all the video footage and them talking through their procedures and protocols. They realized that those nurses, in particular, most likely got contaminated with Ebola in the process of their doffing. And so folks don't understand when they're doffing, how with the correct placement, disposal if they're placing it in the trash, or ways to store it properly, like leaving it on a clean, dry paper towel or inside a paper bag, clean paper bag, ideally in direct sunlight or someplace where it can desiccate for a period of time to let some of that saliva go out with the inside facing out. All right, so that when you don it again very carefully for reuse, you're not bringing the contaminants outside, inside of the mask. So I would say the larger issues for human error that we have are more in regard to doffing than donning. But overall, it is an issue, and there are many peer-reviewed papers on that in Google Scholar. Although, like I mentioned previously, less so done with the general public and more so done in healthcare settings. Yes, but thank you for this question. Okie dokie. I will give it like a pause in case someone's typing something. But if not, please, I think it was mentioned in the answer that this webinar is being recorded. And you can view it again on the ISRP YouTube channel in a few days. Additionally, you're more than welcome to send me an email. You can Google me and easily find my faculty webpage. My email is able@tamu.edu, able@tamu.edu. Just please tell me where you know me from, because I get a bunch of random emails from people every day, and then students emailing me like all the time. So it would be helpful if you put some context with that. But again, thank you so much for providing me an hour of your day and joining the webinar. And with that, I know, John, you have some closing remarks that I'll let you get to.
Yeah, that sounds great. And thank you for the thorough presentation, Dr. Lay. I think this was very, very helpful. And I think it sets the stage for some ISRP activities that are coming up that I wanted to share here for the next minute or two. And please forgive me if I'm a little laborious. I'm working off my laptop in a control room at a hidden location, so it's not as straightforward as doing this in the office. But for the ISRP activities, this is really, I think or I'm hoping it's the first of many future America's Section sponsored events, to talk about pertinent topics regarding respiratory protection. We're looking at scheduling these types of discussions over the next year on a quarterly basis, and hopefully, be able to continue that in the future moving forward. I also wanted to put a plug in that um, we are looking at conducting, the Americas section is looking at having a technical program in conjunction with ASTM's F-23 personal protective clothing and equipment committee week activities in Toronto in June. So we will be putting out some information regarding that as things are firmed up with regard to what the focus of that program will be. Also, this topic that we discussed today about respiratory protection for the public and workers without RPP, this discussion will continue at the ISRP Oxford conference. I understand that the Oxford conference is now full, and hopefully that if you're interested, you'll be able to see proceedings and at least the abstracts on the website for the ISRP to get information about what was discussed at the Oxford conference. Part of that is looking at the questions that were raised with regard to the Face Up project. It's a research activity being sponsored out of the United Kingdom, looking at respiratory protection for children in Southeast Asia. And we're very excited about collaborating with Dr. Howell from the UK, with regard to that activity. And then before we close, I also wanted to put a plug in that next week is NIOSH's Respiratory Protection Week. There will be a webinar that is conducted as part of that. So for details, you can go to the NIOSH and PPTL website, and there's links that you can follow there to register for the Respiratory Protection Week activities. And so with that, thank you for sharing part of your day with us. I hope to see you all again in the near future at a future ISRP event.